year where you see a lot of relapse in the patient. So I don't take vacation during that time. So if you said if you have alcohol problem, it might cause you mania and depression. So we don't call that bipolar. Or if you take cortisone on antidepressants, so there is a lot of bipolar, but not really bipolar. Is mood disorder secondary to medical condition, or secondary to alcohol abuse, or secondary to medication like cortisone. Now, bipolar patients are notorious for using drugs and alcohol. Most of them use alcohol to calm themselves down. All of these, probably 80% of these patients who abuse alcohol are really bipolar, but they are using alcohol to medicate themselves. Also, bipolar have comorbidity with ADHD, attention deficit hyperactivity disorder. So a lot of these patients who are bipolar might also have what we call ADHD or borderline personality disorder, or anxiety or psychosis. Very common with bipolar patient. They have medical comorbidity like obesity. So most patients who are obese and depressed, they might be bipolar. Very common. Diabetes and cardiovascular, very common in bipolar. That's why when you see patients who are depressed but obese and have diabetes or migraine, those are 90% bipolar, not depression, even if they don't have any episode of mania. You need to look carefully before you give them antidepressant. And we said ADHD, impulse control, anxiety, eating disorder is very common with bipolar patient. And usually, if you look at the chronologically of their life, they usually start early in their life, got married, divorced, several times, changing job, divorce, changing job, alcohol, drugs, hospitalization. So their life is always in a yo-yo. Marriage, divorce, changing job, marriage, divorce, changing job. This is how they live. So how we can diagnose bipolar? So when we see a patient who are depressed here, we really need to be very careful in looking up to see if they really have depression or it's part of bipolar. So always do a good screening. Usually, 7 out of 10 patients, they misdiagnose. So if you have 10 depressed patients in my clinic, 7 out of those 10 are really, we misdiagnose them as depression and they are really bipolar. That's why this question always comes in the exam. When you see a patient with depression, make sure it's not part of bipolar depression. So we do like some scale. So the symptom of bipolar, you can put it in your note here, I dig fast. I is for irritability and indiscretion. Indiscretion, that means you make decision quickly without looking at the consequences. Distractibility, for D for distractibility. Insomnia, most of bipolar patients have problem with sleep. They don't sleep well. Grandiosity, they feel very good about themselves. A flight of ideas, a lot of activities. The speech is fast and they don't sleep well. And thoughtlessness means they don't give you deep emotion. If they say they love you, this is really not love. This is superficial, very emotionally. And the money spending. Money spending is one of the issues that is really. So we do something we call Young Mania Rating Scale. Young Mania Rating Scale is done by somebody named Young. It's not for Young, it's somebody named Young. And he asked the patient like from 1 to they have 60 scores. So let's see, you are suspecting that patient have bipolar, so you do the Young Mania score, and he say it's like 30. 30, that's mean you have bipolar. And then you treat him and you do it after 6 months to see how much they improve or they worsen. You do the other Young Mania Rating Scale and you see how much they improve. So it's kind of like the vital sign is the blood pressure for bipolar. So you check how much they are improving in their ability to check them for bipolar. But what is the red flag? Like when I see patient, especially in women, because it's turned to be more in women, how do I know if this woman really depressed or bipolar? Because if she is depressed, real depressed, I give her antidepressant. But if she's depressed and part of bipolar, then I need to worry about giving her a mood stabilizer, not a antidepressant. Because in bipolar depression, we usually don't give antidepressant. It's contraindicated. So how do I know if this lady is really bipolar or maybe she is really depressed? If she had weight increase, so most patients who are obese and depressed, most likely bipolar. If she sleep a lot, so she said excessively sleep, they feel sleepy when they are depressed. or they eat a lot, or they have low energy. So when they are depressed, they are severely low energy, severely sleeping and eating a lot. Remember, in the real depression, you lose your appetite. In bipolar depression, you start eating, you medicate yourself by eating a lot. Or if you have psychiatric symptom when you are depressed, or you have recurrent pattern of depression. Depression comes very quickly and more frequent. Or if you give her antidepressant, or you made her manic, or antidepressant did not work. So whenever you see somebody who had several trials of antidepressant without benefit, then they are not depressed, they are bipolar. Also check for the age of onset. So if she tell you that I was depressed when I was 15 or 13 years old, this is most likely bipolar. Even though they don't have any manic episode yet, just look at for bipolar. Or if they have family history of bipolar, all of these patients might be really depressed, depression of bipolar, not real depression. So look for this red flag. Or if they tell you that they get married many times, they keep marrying and leaving, and this is, or changing job, this is also a red flag for bipolar. How do we know in bipolar? As you know, there is two, biologically, let's talk about biologically now. There is two neurotransmitter, main neurotransmitter. So if you look at the brain, there is two kinds of neurotransmission, mainly, this is 99%. We have Gaba and we have glutamate. Glutamate make you sleep, inhibitory. Glutamate make you excited, and Gaba make you sleep. So this is, they always balance between Gaba and glutamate. For example, in the morning, we have plenty of glutamate, so we wake up and feel energy. At nighttime, we have plenty of Gaba, so we can go and sleep and relax. And there is other neurotransmitter, but mainly the main two is Gaba and glutamate. But there's other neurotransmitter is like glutamate, norepinephrine, for example. Norepinephrine make you alert and awake. Histamine make you alert and awake. That's why when you take antihistamine like cold medication or Panadol night, you fall asleep, because histamine is what wake you up. Acetylcholine also wake you up and make you think, and orexin. So all of this, if you want to make patients sleep, you need to either increase GABA or decrease any of the other neurotransmitter that make you alert. For example, orexin. Orexin is a new neurotransmitter was discovered lately. Orexin increase when you are hungry. So if you are hungry, you go to sleep, you cannot sleep because you have plenty of orexin. So orexin make you what we call alert and cannot go to sleep. Orexin also increase when you are in love. So when you love somebody, you tell her that I couldn't sleep last night thinking about you. Or Kulthum said, Ya Msaharni, Ya Sariq an-Noom min Inayya. Or you're this one who stole the sleeping from my eyes. What do you mean by that is when you are in love, you have a huge increase in the orexin hormone that make you alert all the night. And when you are hungry. So this is what you call orexin. And we have medication now called Belsamra. Belsamra is a medication that decreases orexin and help you sleep. So every time if your fiance or your loved one asks you, do you love me? You tell her, just look how much orexin I have in my blood. Just do orexin, analysis, your blood, and show her how much you love her. I'm just kidding here. So orexin then is a neurotransmitter that increase in two cases, hunger and when you are in love. That's why you cannot sleep if you are hungry. A lot of the time when you cannot fall asleep, you go to the fridge, eat a couple of hamburgers, and you can go sleep again. So bipolar is a brain disease. Look at the brain. You see the brain here in bipolar area is very active. A lot of the brain is this red area in the brain. That's mean the brain is very active, and you cannot go to sleep, or you have a lot of things going through your mind when you are in the manic phase. So what happened is the treatment of bipolar is related to decrease this glutamate hyperactivity. So basically when you have mania, that's mean there is plenty of glutamate in your brain. So when you have a glutamate in the frontal lobe here, you have racing thought, grandiosity, talkativeness, brush of speech. Remember, when you are depressed, what happened when you are depressed? You cannot think, you feel low self-esteem, you cannot talk, you are speechless, you are depressed. The opposite of that is when you have way too much glutamate in your brain and you become the opposite. And instead of thinking, you are racing thought. Instead of self-esteem low, you are grandiose. You are a king or a Jesus or El Mahdi al-Muntazar. You are very distractible because your brain is running, and you are talkative and having risky behavior, because orbitofrontal cortex here down is what make you here, the orbitofrontal cortex, what make you think risky and impulsive, because your orbitofrontal cortex is not working well, and you feel elated and hyper and agitated. So the medication for bipolar, whether there are olanzapine, quetiapine, lithium, they decrease the hyper activities of the glutamate. Glutamate is high. Those medications decrease glutamate hyper level. But is there a cure for medication for bipolar? No. So we don't have any cure for bipolar. We have treatment. It's like diabetes. You don't have a cure for it, but you have treatment. So you give them medication that decrease that glutamate activities, like lithium and antipsychotic. So the treatment is a mood stabilizer called, not antidepressant. Antidepressant makes it worse. Mood stabilizer, like the gold standard is lithium. Lithium is still the gold standard of bipolar. Lithium, lithium, lithium. The other is dopamine or valproic acid, carbamazepine, benzodiazepine, lamotrigine, thyroid hormones. All of them are treatment for bipolar. But if you have a gold standard treatment is lithium. And a typical antipsychotic like quetiapine, olanzapine, risperidone, aripiprazole, lorazepam. There is a new medication called lorazepam, is also for bipolar. But most patients, the typical of bipolar patient, they don't like to take medication. Why? Because the medication slow them down. They love the feeling of high. They love that feeling of I'm energetic. When you give them medication, they don't like it. It slow them down, make them feel horrible. They like that feeling of high. It's very hard. One of the symptoms of bipolar, if the patient doesn't like to take medications, because the other thing is they make them fat. So you have really to talk about it. The new medication, thanks God, will not make them gain weight, but the old medication usually make you fat, real fat. Especially olanzapine and quetiapine and risperidone will make you really, or dopamine or lithium will make you fat and make you sleepy and sluggish. Why? Because we say the SCN, or the biological clock, is the one that wakes the brain up, and it receives the light from the eye. The one that carries that light is called glutamate. And we said that when we give antipsychotic or when we give lithium, they decrease glutamate. You know, glutamate is what make the brain function, make you think, make you awake, make you alert. So when you lower glutamate, the patient will feel sleepy and we feel like we cannot think. We are sluggish in our thought. That's why most patients will not take antipsychotic, will not take lithium. Why? Because they make them feel like a zombie. A zombie in America is a very good phrase for feeling like you are awake, but you are just, barely making it. You just feel tired and sluggish. And bipolar patient does not like that feeling whatsoever. So this is what happened when you take antipsychotic. This is the Mona Lisa. If you put her on antipsychotic or lithium or dopamine, after 1 year, she'll be like this. And that's why they don't like to take medication. I don't blame them, because these medications have a lot of side effects. Thanks God, the medication, usually like quetiapine and olanzapine, they help patients sleep. And we said the notorious things in bipolar patient is they don't sleep. Sleep always a problem in bipolar. So when you give them antipsychotic or lithium or dopamine, they sleep very well. This is like you hit two birds and one stone. One, you improve sleep. Second, you decrease glutamate and you help with bipolar. However, because if you don't sleep, you become manic. So one of the reasons why patients become manic is like you see bipolar patient doing well for 3-4 months. They had some problem for 2 or 3 days. They couldn't sleep. They become manic again, because any lack of sleep will activate the manic phase in our environment. It's part of the brain that make you alert and make you awake and become impulsive and agitated. It's called the striatum. We're going to talk about it next week in the addiction lectures. The question now, we said, this is very, very important, guys. We said lithium is the gold standard of treatment of bipolar. And it's really one of the best medication for bipolar. But if I put 100 patients on lithium today, how many of them will stay on lithium next week? None of them. Most patients, 99.9% of the patients you put on lithium, they will stop it after 1 month. Why? Even though it's the only medication, lithium and valproic acid is the two medications that make the brain grow, make gray matter grow. So you have a new brain cells. What more do you want? You have a new brain cells. Very good. Even I want to take lithium myself. It's make my brain grow. But bipolar patient, and even me, I will not take lithium. Why? Even though it makes your brain grow, because of the side effect. Most patients cannot tolerate the side effect where you are groggy, and you are gaining weight, and you are doing nothing. Your brain is growing, but you are like a couch potato, not doing anything. And bipolar patients don't like that feeling. Always remember, they like that good high feeling. So there is a new medication now in the market. There's a lot of a new medication, like we have one called lorazepam, lamotrigine, aripiprazole. Those are a new medication for bipolar, and there is like 20 more came in the last 2 years, and all of them will not make you gain weight. So that's why we are not using the old medication now. We are using the newer medication like lorazepam, aripiprazole, and lamotrigine. And there is 6 other medication. I did not put them here. So do we have time to take the story of Anna, or we'll wait until the break? Let's wait until the break, and let's have question and answer from you. Any question?
Doctor, can I just ask you a question?
What should I do now? Let me see the chat. They hate being sluggish, yes. Is there any question? Anybody want to raise his hand and ask question?
Yes, doctor.
Yes.
Yes, doctor, I have a question. I don't understand the difference between bipolar 1 and bipolar 2.
Okay, bipolar 1 is like when you are a billionaire, have billion of dollars. Bipolar 2 is like you are rich, a little bit rich. So bipolar 1 is more severe form, like you have psychosis, you have paranoia, you feel like you are al-Mahdi al-Muntazar, you go to the hospital for lack of sleep, you lost all of your money or your family's money. This is bipolar 1. But bipolar 2 is you are very active, you don't sleep a little bit too much, and you make a lot of things at once, but it does not impair your social function, and you don't have any paranoia or hallucination, and you don't need to be hospitalized. Is that clear? If you have bipolar, yes. Yeah, if you have bipolar, it's very heritable. So your kids will have bipolar most likely. Okay. Usually it starts around teenager years. Teenager year, if you have any stress. So most of us will might have bipolar, but you don't show it because it's not triggered. We're going to talk about it now in the next lecture, inshallah. So it usually showed up in the teenager year, late teenager years. Yes, ADHD and bipolar are 40% comorbidity. Most patients of ADHD had bipolar. Most patients with bipolar have ADHD. In fact, in children, it's almost impossible to diagnose whether he had bipolar or ADHD. So a lot of the patients in my clinic who are teenager ended up on medication for ADHD and medication for bipolar, because there's most of the patient, 40% will have both. Yes, the first episode of bipolar, usually depression. So you need to make good story, good way to deal with it before you said it is bipolar or depression. Now, I will leave the case of Anna. I will not talk about her. Just read it, and it's very, very self-explanatory, and see about it. If the parents suffer from bipolar, yes, it's hereditary. Yes, it will most likely happen in the family. Yes, this is very common in families. Should we take a 5-minute break, then come back? Guys, girls, if you have any question, please send me on WhatsApp your question and I'll answer it in detail, inshallah. So let's take a break and come back in about 5 minutes so we can start, okay?